All right. Thank you all so much for attending and for having me here today. I'm very excited to talk to you about this topic of bacteremia because it's something that I help to manage every day, and I'm guessing that a lot of you in the room do as well. So we'll jump right in. So we're going to be talking about literature that assesses duration of therapy for different types of bacteremia. We'll also look at ways to develop a definition for uncomplicated bacteremia, or now the new buzzword for Staph aureus will be low-risk bacteremia. And then we'll compare some bioavailability and efficacy of oral antibiotics for the treatment of bacteremia. There's a lot of abbreviations in here, so I included a list in case you look back at this at some point, but I will talk through them as we go. So bloodstream infections are very big causes of significant morbidity and mortality in our patients. Mortality rate for bloodstream infections in sepsis range anywhere from 10 to 40% nationally, and we see over 20 billion in healthcare costs related to this. There was a really nice paper published by Dykema and colleagues in 2019, and this is Sentry data looking at what pathogens we see in bloodstream infections internationally. So they looked at over 250,000 pathogens in bloodstream infections from 200 plus medical centers in 45 nations, including several in the US. And what you see here is that we have a lot of Staph aureus, we have a lot of E. coli, and then a little bit distant from there, we have Klebsiella, Pseudomonas, Enterococcus, and a lot of other Enterobacterales. So just to give us an idea of what types of pathogens we're seeing in our bloodstream infections. So the way I've set this up, we're going to start talking about gram-negative pathogens, and then we'll go into gram-positive. In each of these sections, we'll talk about duration and then route of therapy. So to give us some framework for gram-negative bacteremia, we need to talk about what an uncomplicated bacteremia looks like. So in 2021, we had a panel of experts, including 7 ID physicians, 6 ID pharmacists, experts in the field, that came together and put out a consensus document. Now, I want to point out that at this time, there were about 2 randomized controlled trials that were published, but the big one, Balance, that we've all probably heard about, was not published at the time they put this out. So just keep that in mind. They did a modified Delphi process. So basically sent out a questionnaire with 11 different questions to these panelists, had them submit their answers, made statements out of those, sent them back out, and asked them how much they agreed or disagreed with that statement on a 7-point Likert scale. Collected it, refined the statements, sent them back out, looked at a 5-point scale, and then sent it out one more additional time to see if they agreed with the statements. So what they came up with for uncomplicated bacteremia was a bacteremia secondary to a source of UTI, skin or soft tissue infection, intra-abdominal or biliary infection, catheter-related, or from a pneumonia respiratory source, but they excluded empyema if they had structural lung disease, cystic fibrosis, or an undrained abscess. They also commented on source control, so we need removal of any hardware, catheters, devices. We don't want any metastatic residual foci of infection. The immune status category was actually where they had a lot of discussion and difficulty in determining who to include here. But at the time, they decided on patients who were not immunocompromised or not at risk of opportunistic infections would be included in this uncomplicated category. And they were pretty broad with this. So they included recent solid organ transplant, prolonged neutropenia during treatment, CD4 count less than 200, and then chronic corticosteroid immunomodulator therapy in patients that would need opportunistic infection prophylaxis. So we'll refine this a little bit as we go on, but this is kind of the starting point. And then clinical improvement at 72 hours, including defervescence and hemodynamic stability. So what do we have in guidelines about therapy duration? Not too much. We don't really have a gram-negative bacteremia treatment guideline. So we can turn to the management of intravascular catheter-related infections, and we see in their recommendations anywhere from 7 to 14 days. So if we look at the early 2000s and really prior to these new randomized controlled trials that came out, really the standard when we look at surveys and data collected was 14 days pretty much across the board. We see prior to 2019 a lot of studies looking at other indications like UTI, ventilator-associated pneumonia, skin and soft tissue infection, where we're starting to be able to use less and less days of therapy. So the natural question came, is 7 days sufficient for bloodstream infections also? So luckily, we're at a point now where we do have 4 published randomized controlled trials and then 2 meta-analysis that look at different combinations of those 4 randomized controlled trials to help us answer these questions. I really quickly just want to mention what the issues are and why we're trying to decide what the optimal duration is, and not to foreshadow where we're going, but we do really need a good balance, right? So we don't want too short where we would see clinical failure or maybe resistance built up. We don't want too long where we're maybe putting the patients at risk for more adverse drug events, maybe more disruption to their microbiome, potentially more C. diff, although in the trials we see very low numbers of C. diff in the results. Potentially increased hospital length of stay, and maybe more development of resistance. So it's a really fine balance that we need to figure out in terms of days of therapy. So we'll look at our first trial that came out in 2019 by Yahav and colleagues, and this was 7 versus 14 days of therapy for uncomplicated gram-negative bacteremia. They included hospital adults with gram-negative bloodstream infections and had to be hemodynamically stable and afebrile for greater than 48 hours to be randomized in, with the sources very similar to what we saw in our uncomplicated. So urinary, intra-abdominal, respiratory from a catheter, skin and soft tissue. They included any patients who had an uncontrolled foci of infection or endocarditis, bone and joint, things like that. They had pretty broad definition for immunocompromised patients that they excluded, including neutropenia, HIV, recent transplant. And then there were some pathogens that they deemed difficult to treat that they excluded. Randomized patients 1-to-1 to either 7 or 14 days with a primary composite of all-cause mortality, clinical failure, readmission, or extended hospital stay at 90 days from randomization, and used a 10% non-inferiority margin here. And in their intention to treat and per protocol populations, they did find that 7 days was non-inferior to 14. The per protocol included patients that got the correct number of days plus or minus 2 days. What I want to point out is that 63% of these patients had E. coli infections, 13% Klebsiella, so those were really our big two. 68% were from a urinary source, followed by intra-abdominal. We have very little variety of other bacteria included, so less than 1% Acinetobacter, only 8% Pseudomonas, minimal number of ESBLs. The primary driver of the primary outcome in both groups was readmissions, so just something to be aware of. And we had 73% of patients that were switched to oral antibiotics at some point, with 74% of those being fluoroquinolones. So that'll foreshadow our IV to PO discussions. The next trial that we want to talk about is Van Dijk and colleagues that was published in JAMA in 2020. They also looked at 7 versus 14 days of treatment, but they also included a third group, which was a CRP guided group. So basically, if the patients had a CRP that dropped 75% from peak, they would stop their antibiotics at that time. So very similar criteria. These patients had to be at day 5 plus or minus 1 day with efficacious therapy, also afebrile greater than 24 hours, no complicated infections. They have a few other pathogens they excluded as difficult to treat and had very similar broad category for the immunosuppressed patients. Patients randomized 1-to-1-to-1 into the groups, and the primary outcome was clinical failure at day 30, which included recurrent bacteremia, a distant complication, restarting antibiotic therapy, or death from any cause. They also used a 10% non-inferiority margin. And in both the intention to treat and per protocol, they saw non-inferiority with 7 versus 14 days. Again here, very large number of urinary infections, very large number of E. coli, followed closely with intra-abdominal and Klebsiella, similarly to the previous trial. What I want to point out here is very interesting. In that CRP group, they had a 7-day was their typical duration, the median duration, but it ranged from 5 to 28 days. So there were actually 14 patients that got 5 days of therapy and 29 that got 6 days of therapy. So this opens the door to the question, can we go lower than 7, which is interesting. They did have a lower observed event rate than the previous trial, but they did not include readmissions. So that was probably the reason for that. Okay, and then finally, the big trial that a lot of us have probably heard a lot about is the BALANCE trial. So this was bacteremia antibiotic length actually needed for clinical efficacy. This was a huge trial done over almost 10 years, 74 sites in 7 countries. And they had very broad inclusion criteria. So it was basically anyone hospitalized with a pathogenic bacteria in their blood culture. They started out in the ICU because one of the co-leads of the trial was in the Canadian Critical Care in trial group. And so they had a really good foundation for starting their trials and a good framework and mentorship for this. In terms of their exclusion criteria, they were a little bit more tight with immunosuppressive patients and only excluded those that were neutropenic or post-transplant. They did exclude prosthetic heart valve and endovascular graft patients because they included gram-positive bacteremia as well. And then similar to the other trials, infections requiring prolonged therapy, so our endocarditis, bone and joint infections and that. And they did exclude any patients with common contaminants in their blood culture. And then key here, they also excluded Staph aureus and Staph lugdunensis, which we'll talk a little bit more about later. So randomized 1-to-1 in 7 versus 14 days. Their primary outcome was death from any cause at 90 days. And this is kind of interesting. If you look at the numbers here for intention to treat and per protocol, they are quite different by several hundred patients. They had a lot of deviation from the protocol because the providers were able to extend the therapy if they felt necessary for the patients, which was applicable to the real world, but it can kind of have an effect on the results. So per protocol, again, was if they treated with the appropriate number of days plus or minus 2 days. So you can see that several of them actually got longer. It was 23% in the 7-day group that got longer therapy and about 13% in the 14-day group. The median number of days in the 7-day group was actually 8 days for the trial. So something to be aware of. But they did intention to treat per protocol and a modified intention to treat where they excluded any patients that died prior to 7 days of therapy. And there was non-inferiority across all 3 groups. So that is a good thing. You can see they had over 2,000 gram-negative pathogens, 625 gram-positive. They, again, were very heavily weighted with E. coli at 44%. About 60% of these patients got oral antibiotic at some point. And these patients were randomized up to day 7, but they had a prolonged allocation concealment. So the providers treating didn't know which group they were randomized into until that day 7. So just some additional details from here. In terms of these patients, we had 55% that were in the ICU at some point, 21% with mechanical ventilation, 21% that had a solid organ cancer, 12% that were on chemo or had glucocorticoid greater than 15 milligrams per day. So this really broadens the amount of patients that we can think about for this shorter course therapy. You can see, again, heavily urinary and intra-abdominal sources here. They did have a pretty substantial number of Pseudomonas patients, so 170, and then also 421 with polymicrobial bacteremia. So when we go back to our definition of uncomplicated bacteremia, we still see that with all these trials, they're really excluding any of those kind of more severe infections where we need longer durations of therapy. And that, I think, still stands, going forward. With source control, we have some questions that remain. So what about patients who have obstructing stones, catheters, percutaneous nephrostomy tubes? We don't get much detail about that in any of these. Also, what if the central venous catheter is left in place? With immune status, I think Balance trial opens the door for us a little bit with some of these patients with chronic corticosteroids, immune modulator therapy, maybe thinking we can start with a 7-day minimum there and then individualizing per patient. And then finally, in terms of pathogens, we see very heavy Enterobacterales coverage in the trials. So can we extrapolate beyond that to the other pathogens? And there's a lot more coming out related to this. The group that had the general consensus statement with the modified Delphi process didn't think that we needed to differentiate between multi-drug resistant pathogens and non-multi-drug resistant pathogens, as long as we had an efficacious drug that could reach good serum concentration for that pathogen. So I just want to address some ongoing studies that might help us answer some of these questions. There's a Balance trial sub-study that's looking at the treatment of bacteremic urinary sepsis, where we may get some of those questions answered about the obstructing stones and stents. There's also a Balance Plus trial with the same authors that's a multi-domain platform. So they're trying to answer multiple questions at one time. So they're looking at whether we de-escalate versus non-de-escalate in these patients, routine versus non-routine blood culture follow-up, oral beta-lactam versus non-oral beta-lactam, which I think will be very helpful. whether or not we leave in a central venous catheter. And then they're also going to look at some of these low-risk AMP-Cs, so Serratia morganella providencia, and using ceftriaxone versus carbapenem in those situations. Now, I haven't seen this in the protocol, but in an interview the authors did, they also mentioned looking at perhaps less than 7 days for some of these very low-risk patients. So we may see that in the near future as well. There's another trial, Shorten 2, that's a randomized controlled trial to assess superiority of 7 days versus 14 for Pseudomonas bloodstream infections. And this was actually presented at the Spanish Society of Infectious Disease in May, and it looks like we have pretty favorable results there. They did a desirability of outcomes ranking, so they're taking into account both the efficacy and like the side effects and things like that of the patient. So look for this. We should have a publication very soon that may give us more answers about Pseudomonas. So I want to share just quickly some of our experiences at the 4 hospitals that I oversee. And we were trying to look through a continuum of time at where we stood in terms of duration of therapies. So I want to shout out Dr. Ellen Akery, who's sitting in the crowd over there, who was one of the leads on this, looking into this. And so we looked at over 1,000 patients by retrospective chart review who had E. coli, Klebsiella, and Proteus in their blood. We were looking for duration of therapy as well as length of stay, all-cause mortality in hospital, and 30-day readmission over 3 different time periods. So 2018 to August of 2019, this was our baseline population. And then in September of 2019, we made any gram-negative pathogen in the blood a mandatory ID consult at all of our sites. And interestingly, all of our ID providers are employed by our system. So we had very good buy-in within that group with looking at these patients with gram-negative bacteremia. We made one final change in June of 2020, putting together a gram-negative bloodstream infection algorithm for treatment. And so we wanted to see if that had an impact on our durations as well. So please remember, this was before the BALANCE trial came out, but this was what our algorithm looked like. So we basically said if we have a monomicrobial Enterobacterales bloodstream infection, they're immunocompetent, have adequate source control, hemodynamically stable, and can tolerate and absorb oral medications. We excluded bone and joint, CNS, endovascular infections, or persistently positive blood cultures. Then we would recommend they could either finish a 7-day course of IV or be transitioned to a fluoroquinolone or Bactrim at any time for a total of 7 days. And then we were very conservative with beta-lactams because there just wasn't much data at the time. But we said you could go to a PO beta-lactam after 5 days of IV for a total of about 10 to 14 days. And when we looked at our results here, going from the baseline, we had 14 days, which was right in line with what we were seeing nationally. Putting in the ID consult really didn't change anything. We were at 13 days there. But after we put the algorithm in place, we went down to 11 days, and this was statistically significantly different. So the reason I wanted to mention this is that we have a lot of great pieces of literature and trials that come out, but they don't necessarily always translate into action into our hospitals too quickly, right? So putting together something like an algorithm to help the providers know who the best patients are that fit these trials and who we can potentially shorten course of therapy can be very helpful in the institution. So we'll just do a quick knowledge check question here. According to that literature that we just reviewed, who would best fit the evidence for a 7-day antibiotic total course? Who would we feel most comfortable? So is it A, a Pseudomonas aeruginosa bacteremia, clinically stable at day 3 with a pulmonary source? B, an E. coli bacteremia, clinically stable by day 4 with urinary source? C, Proteus bacteremia with undrained abdominal source? And Serratia marcescens bacteremia from osteomyelitis. So just by show of hands, who would say A? Okay, we have one taker. How about B? Okay, C, D. Okay, so great. I'm glad you raised your hand for A. I would argue that we have mounting evidence that we can probably get to that as well for A, but I think we have the most evidence for B at this point. So the E. coli bacteremia from a urinary source. But I think you're right. We're probably on the continuum where those low-risk patients with Pseudomonas pulmonary source, we may be able to do that as well. The undrained abscess and osteo, we still need longer-term course therapy there. Okay, so we'll switch over to talking about route of therapy here. IV to PO, as many of you know, is one of the core elements of antimicrobial stewardship. We get lots of benefits from it, increased nursing capacity, reduced risk of line infections, decreased cost. There's a ton of trials out there about IV to PO. So I tried to pick some that had really good pearls for you guys. One is Punjabi and colleagues in 2019, which was a meta-analysis of 8 retrospective studies over 2,000 patients. And they looked at oral fluoroquinolone or Bactrim versus beta-lactams and found no significant difference of death between the groups. They did, however, find more recurrence in patients that were transitioned to beta-lactams. But the reason I put this in here and why I want to point this out is when we go back through those studies, a lot of the patients that got beta-lactams actually got doses lower than what we would currently recommend for bacteremia. So this is kind of my cautionary tale. When you're looking at these studies, you really have to look at the doses that they're getting and be careful that we're achieving good serum concentrations. I included this Tingsgaard and colleagues from 2024 because this was actually an emulation study for a randomized controlled trial that is currently going on. So it gives us just a little bit of what we might see from this clinical trial. These were uncomplicated gram-negative bloodstream infections in 4 hospitals in Denmark, and they looked at a switch from IV to PO around day 4. And then the patients would either continue on to get a full 7 to 14-day course. Again, excluded a lot of pathogens, a lot of patients with immunocompromise, but looked at 90-day all-cause mortality, and they found no difference in switching from IV to PO versus IV in these patients. Interestingly here, about 63% of these patients got beta-lactams, so more beta-lactams than ciprofloxacin or trimethoprim sulfamethoxazole. Okay, we do have a randomized controlled trial that looked at IV to PO therapy by Omrani and colleagues in 2024. And this was at 11 sites in 4 countries, including Bahrain, Kuwait, Qatar, and Turkey. You can see here that they looked mostly at Enterobacterales. And basically, the patients had to get 3 to 5 days of IV therapy. They excluded a lot of those high-risk groups, again, a lot of those immunocompromised patients. They looked for a primary outcome of composite death, additional antibiotics, relapse, or infection-related readmissions within 90 days, and found no difference between the IV group and the IV to PO switch. This trial was unfortunately affected by COVID, and they had originally sought to have 438 patients in the trial and did not come anywhere near that. So it's really not powered for the results that they got, but I still think we can take a little bit away from it. But you'll notice that like the 95% confidence interval is pretty wide there, really because of the low number of patients that they had. But again, 60% urinary source, 67% E. coli. Okay, a couple more. So Liu and colleagues, this is actually one that was published just this year. And this is looking at data from Kaiser Permanente from 2018 to 2022 at adults with gram-negative bloodstream infections. What I think is really interesting about this one, because they're pulling data from 2018 to 2022, look at how many patients ended up in the IV to PO switch versus the IV. So this just shows you at a lot of our sites now, we are really switching these patients over to oral therapy. So I had over 8,000 in the switch group and only 900 that got full IV therapy. They looked here for a primary composite outcome of all-cause mortality, readmission, or recurrence of the gram-negative bloodstream infection. Again, very heavily leaning towards E. coli, so 68% there. And they found no difference in all-cause mortality, but they did see significantly more readmissions and recurrent bloodstream infections in the IV group, which is very interesting. Another thing that I want to point out here is that, again, they found that recurrence was lower with oral fluoroquinolones than with beta-lactams, but it's kind of interesting the choice of beta-lactams that they use, and we'll talk about this a little bit more in just a second, but they had 49% that got cefpodoxime, 26% that got cefadroxil, and about 9% that got cephalexin. Interestingly, they said that there was more recurrence in the cefadroxil and cephalexin patients than in the cefpodoxime. So we'll talk about that more, but just a little interesting thing. And then finally, from 2025, Lee and colleagues, this was a meta-analysis of 6 randomized controlled trials, 32 cohort studies, over 11,000 patients. This is a very robust paper. There's a lot of different endpoints that you can go and explore if you wish to. I just pulled out a couple here for us. So they looked at treatment failure between IV and IV to PO switch in 6 randomized controlled trials comprising over 529 patients and did not find a difference there. There was very minimal heterogeneity between these studies. There was another group that they looked at with 7 studies that was a mix of the randomized controlled trials and cohort studies. It's about 1,600 patients looking at 90-day mortality, and also did not find a difference between the IV and IV to PO switch group, but there was significant heterogeneity among these studies. So just something to keep in mind there. Okay, so from that group that gave us the guidance consensus, they did say in 2021 that oral therapy could be considered if we had clinical improvement on IV therapy, source control was achieved, we had antibiotics that were active per the susceptibility data, functional GI tract. And then they did point out that PK/PD target attainment might not be possible with all oral beta-lactams, so it's something that we have to watch out for. And then we really have to account for patient clinical factors and allergies. So this was the proposed table that they presented in their publication for doses to potentially use for gram-negative bacteremias. And you can see at the top, we have a couple fluoroquinolones and then trimethoprim sulfamethoxazole. I think there's still a little bit of debate about what dose of trimethoprim sulfamethoxazole we need for bacteremia. Traditionally, in my practice, I've done about 4 mg per kg twice a day. They recommend 5 mg per kg twice a day here. So there's definitely some variability in practice, and I think some answers still to be figured out there. What's really interesting is the oral beta-lactams. And so you can see they were recommending amoxicillin, amoxiclav, and cephalexin. And you can see the comparative bioavailability is there, but the bioavailability isn't everything. We need to make sure that we get enough of the antibiotic to the site of infection, have good concentrations. With beta-lactams in particular, we need free drug above the minimum inhibitory concentration, or MIC, for a certain amount of time, and we refer to that as the target attainment. So they actually put in here for Enterobacterales what target attainment we needed to achieve, and basically said that if we use these doses here, which are higher doses for the beta-lactams, that we could achieve that target attainment up to an MIC of 2 for each of those medications. They interestingly said there's lack of PK/PD data to support the use of cefadroxil, cefpodoxime, or ceftonir. So cefadroxil we have challenges with because the FDA and CLSI tell us we cannot use cefazolin, IV cefazolin, as a marker of whether or not cefadroxil is effective for patients. Most of our laboratories don't test susceptibility data or give us MICs for cefadroxil, so it makes it kind of challenging to use. I think the jury is still out on cefpodoxime, and many trials included it, use it. We've used it on a good number of patients. So there's not robust PK/PD data, but I think that with high doses, potentially, still an option, but I think the jury's still out on that. And then there's several that are here that really just do not get good systemic absorption that we should avoid. So there are a few ongoing trials to keep an eye out for. Like we already mentioned, that Balance Plus, but also the GOAT. So that's gram-negative bacteremia oral antibiotic therapy, which is randomized controlled trial in 9 US hospitals looking at IV versus IV to PO at day 5. And they are doing that desirability of outcomes ranking style. The INVEST trial is an international non-inferiority randomized controlled trial looking at fluoroquinolone or trimethoprim sulfamethoxazole versus IV therapy. And that's the one that we had that emulation study. So it'll be interesting to see if we come up with similar outcomes there. So just in conclusion, some implementation strategies for gram-negative bacteremia. I think we do have sufficient evidence for 7-day course with early oral switch, and we see a lot of our institutions, already doing this for our uncomplicated gram-negative bloodstream infections. It's really finding those correct patients to apply this to. We want to engage a multidisciplinary team, so our providers identifying and achieving source control for patients, pharmacists helping out with PK/PD, stop dates, criteria verification. Nurses can do a lot to help with allergy documentation, the clinical picture of the patient. Antimicrobial stewardship, where I think we can be really helpful, is developing some standardized algorithms or checklists to help our providers understand which patients fit into these categories of being potential targets for lower short course therapy or IV to PO, and then really having standardized recommendations for IV to PO based on your formularies and the kinetic data. And then finally, microbiology partners, so perhaps some pathogen comments or figuring out what susceptibility data we're going to provide to our providers. So we want to reassess patients around day 3 to 5 or when their susceptibility data come back. consider that checklist about uncomplicated bacteremia. We really, really need to individualize for patients, though. I think that's kind of where all this is going is, we have a minimum 7 days, and then you kind of build from there as needed. Standardize those IV to PO recommendations, and then counting our days from first active dose. Okay, so we're going to switch over into gram-positive now. In terms of definition of uncomplicated or low risk, we do have the MRSA bloodstream infection kind of older guidelines that tell us for uncomplicated, we exclude endocarditis. If they have an implanted prosthesis, they have to have repeat blood cultures that are negative within 2 to 4 days, that same defervescence, and no evidence of metastatic foci of infection. Interestingly, there were 2026 updates to this from IDSA and the European Society of ID and Microbiology that were kind of put out last week, and then they seem to be retracted. So keep an eye out for those, but they've kind of disappeared from their website. But they are changing the categories from uncomplicated and complicated over to low risk or increased risk framework, where they're really trying to stratify patients on their risk for deep-seated foci or relapse. And I just put in a plug here. There's many, many papers now that support mandatory ID consults for Staph aureus bacteremia. So that is also a great option to consider for patients. In terms of duration of therapy and guidelines, both those old MRSA bacteremia and the updated ones that came out and disappeared still recommend the 2-week course for Staph aureus bacteremia. So we're not really changing our duration there. And then if it's complicated, typically 4+ weeks. In terms of our enterococcus, strep, really the only thing, we kind of have to turn to is that intravascular catheter-related infection guidance, kind of 7 to 14 days there, but historically most people had been doing 14. Typically with gram-positives, day 1 of therapy is the first day that we have a negative blood culture obtained. So with Staph aureus, like I said, we're not looking to minimize our 14 days of therapy, but can we do some IV to PO switch? So we do have the Sabato trial that was published in 2024. This is a little challenging because there's a lot of exclusion criteria. So this was a non-inferiority randomized controlled trial. Patients had to have Staph aureus in at least 1 blood culture, get at least 5 to 7 days of appropriate IV therapy, and then they had to have a follow-up blood culture within 24 to 96 hours that was negative. You can see they couldn't have a complicated bloodstream infection. If they had septic shock within 4 days or fever within 2 days, they could not be randomized into the trial. If they had a recent history of a Staph aureus bloodstream infection, they would be left out. So they randomized 1-to-1 to either continued IV or IV to PO switch, and a 14-day total course with a primary outcome of composite of relapsing Staph aureus bloodstream infection, deep-seated infection with Staph aureus, or death attributable to Staph aureus bloodstream infection. They wanted to use a 5% non-inferiority margin here, which would have required 430 patients, but they had very slow recruitment, so they actually ended the trial at a certain number and then pushed the non-inferiority margin out to 10. So something to keep in mind. And you'll see here when we look at the primary composite outcome, they did find that there was no difference between the groups, but our 95% confidence interval is pretty wide there. So a little hard to kind of apply this out. Unfortunately, they didn't really meet the original numbers that they were hoping to. Also, only 16% of these patients, 16 patients, 8% had MRSA bloodstream infections, 92% had MSSA. 65 were from catheter-related sources, 22% skin and soft tissue, and they had a median day of the IV therapy of 6 days. And then interestingly, their way of placing patients into oral therapy was to start with trimethoprim sulfamethoxazole as their primary agent. If they couldn't get that because of some factor, then they went with clindamycin. And then beyond that, they would go with linezolid. So a little different, I think, than a lot of us would probably do here, but just good background to know which agents they chose. We already talked about this study. This was the 6 randomized controlled trials and 32 cohort studies put together, but I wanted to pull out a couple of the endpoints that looked at gram-positive here. And so they did look at early oral switch versus IV subgroup analysis for both Staphylococcus and Streptococcus, and they found no difference between the groups there. So you can see they had 3 studies, a little over 500 patients in the Staph group, 2 studies, a little over 300 patients in the Strep group. So just a little bit more evidence of being okay to switch to PO in those scenarios. There is an ongoing trial with the Staphylococcus aureus network adaptive platform. So this is another one of those big domain studies that they're trying to answer multiple questions at once. And they're looking at early oral antibiotic switch for IV for Staph aureus bacteremia. And you can see here, these are all the different antibiotics that they're proposing to look at and include in this. So keep an eye out for the results here. This may give us just a little bit more evidence in terms of Staph aureus IV to PO. And then I want to pull back in the BALANCE trial. Remember here that we excluded prosthetic heart valves, endovascular grafts, Staph aureus, and Staph lugdunensis. But they did have a very large number of patients with Enterococcus, so about 250. This was the third highest pathogen in the trial. And if we compile all the strep together, they do also have a pretty significant number of strep. Now, different strep species have different risk for complications, but there's a pretty substantial amount. So we can be pretty confident that at least in some patients with Enterococcus or strep, that we could potentially go with a 7-day course of therapy and then individualize from there. In terms of strep, we have a little bit more evidence from retrospective studies. So one trial by Clutter and colleagues in 2024, again, out of Kaiser Permanente, that looked at patients that had strep bloodstream infections and looking for a composite 90-day all-cause mortality. They looked at both duration of therapy and IV to PO switch. So they looked at either 5 to 10 days versus 11 to 15 days. The median for the group was 9 days in the shorter course and 14 in the longer course, and they found no difference there. In the IV versus IV to oral, again, they found no difference. And then Crotty and colleagues in 2024, this was a single center retrospective out of Texas, also again looking at strep, and they looked at a 30-day composite clinical failure, which included all-cause mortality, readmission, and bloodstream recurrence. And they looked at less than 10 days versus greater than 10 days, and again, found no difference. In the first trial by Clutter and colleagues, that was the highest amount were skin and soft tissue infections followed closely by pneumonia. In Crotty and colleagues, you can see almost all of them were from pneumonia source, so 50 out of the 51 in the shorter course group and 96 out of the 111 in the longer course group. And then finally, for Enterococcus, Zimmerman and colleagues in Switzerland, they looked at patients with blood cultures with Enterococcus with a primary endpoint of mortality, recurrence, or development of a bone and joint infection within 120 days of the bloodstream infection. They looked here at a short course of 4 to 10 days versus a longer course of 11 to 18 days, found no difference there. The median total days in the groups was 8 versus 13 in the intention to treat group. And they had early oral switch in about 20% of the patients, but they don't give us much information about the particular agents used. And then just as a breakdown, we had about 187 E. faecalis, 137 Enterococcus faecium. There is an ongoing trial, the INTENSE trial, that's a multi-center non-inferiority randomized controlled trial. They're trying to achieve a 6% non-inferiority margin, looking at 7 versus 14 days of uncomplicated enterococcal bloodstream infections. So again, another trial that will really hopefully give us a little bit more information about these patients. So in terms of gram-positive, where do we stand? I think with Staph aureus, minimum 14 days is still where we're at. In terms of early oral switch, yes, we can consider individualizing per patients. With Enterococcus and strep, BALANCE really gives us a good amount of literature and backing, along with some of our retrospective trials, that we really can start with a minimum of 7 days and then expand out from there based on different clinical factors. And same thing with early oral switch. We seem to have non-inferior outcomes, or at least similarly statistical outcomes with patients on all IV versus IV to oral switch. In terms of the table here, I just really added linezolid with good 100% oral bioavailability there, but we really have to take into account the PK/PD for all of these pathogen and drug combinations. And so I would really encourage you to engage pharmacy support for this. It would have been challenging in the time limitation that we have to really get into in depth with the Enterococcus, strep, and staph for this. Okay, so our second knowledge check here for gram-positive. Where do we feel best about evidence for a 7-day course for our gram-positives? If we have a strep mitis bloodstream infection from an infective endocarditis source, afebrile at day 4, a Staph lugdunensis bloodstream infection, skin and soft tissue infection source with a recent total knee arthroplasty, Enterococcus faecalis bloodstream infection from an unknown source with mitral valve replacement 6 months ago, or strep pneumonia bloodstream infection, pneumonia source, no abscess empyema. So show of hands for A. B, C, D. Okay, great. So yeah, I think the evidence is pretty strong now for a strep pneumonia, a patient that responds to therapy quickly, no abscess empyema. It is fair to consider a shorter course than those patients. Great. Okay, and then so just to kind of wrap up here with implementation strategies for gram-positive bloodstream infections, I do think we have evidence now to support 7-day course with early oral antibiotic switch in our very low-risk patients who respond quickly to therapy in enterococcal or strep bacteremia. Of course, with the Staph aureus bacteremia, we're still staying at a 14-day mark there. And then again, we want to engage that multidisciplinary team and reassess our patients at day 3 to 5 or whenever we get our susceptibility results. At our institutions, we actually get all of our microbiologic results in real time, go straight to our pharmacists. So we're able to act on those in real time, which is really nice. So we don't really use an antibiotic timeout that serves as that for our population. That works really well. And then consider again, like a low risk bacteremia algorithm checklist for these patients with gram-positive bacteremia. I think the jury is still out on whether they have a prosthetic device because they did exclude them from the BALANCE trial, even if they didn't have a risk of infective endocarditis or a thought that they had infective endocarditis. So unfortunately, we still have a little bit of a question there. I will say that a lot of our providers, if we have a known source of a respiratory infection or skin and soft tissue with a strep, and even if we have one of those devices in place, you know, there are certain situations where we may still consider the lower course, but we still need maybe some more answers with that. And again, really, we want to individualize per the patient. So we have these 7-day minimums, but then kind of pan out from there based on the clinical response and other factors from the patients. And then again, try to standardize IV to PO according to your formulary, just to really help providers out in making those decisions. Okay, and at this time, I will take any questions. Yeah.
I know you didn't cover this in your talk, but if you give a little bit of time and your thoughts on like a IV to PO switch for endocarditis and kind of what your experience with that has been.
Yes. So I had a really difficult time, I'm not going to lie, trying to kind of limit the information because this is such a robust topic. So I did want to include things like the POET trial. We also have COPAT trial. So we do have, you know, pretty decent evidence that in some of those really kind of, you know, low risk, good response patients of converting over to PO therapy. We have done that with some of our patients. The other interesting one that I'll add on that I was going to include, but I was afraid I would run out of time, was the DOTS trial that we have now too, looking at dalbavancin to discharge patients. So maybe they don't necessarily need like a PICC line to go. And so there are different modalities that we can look into, but certainly, yes, the POET trial and the COPAT trial do give a little bit more evidence into some of these more complicated infections and being able to switch over to early oral therapy. Yes.
In your experience, have you ran into a significant amount of bone marrow suppression with extended courses of the Naegele? That's always a thing.
So I will say that we don't use very much linezolid at my sites. Over a decade ago, we had a poor outcome with serotonin syndrome in one, and I think that that's had kind of long-term effects. So we probably use less linezolid than most other places. I think there's still a lot of questions in the realm of transplant patients. I know that there's some work, you know, kind of being done from University of North Carolina, looking into those patients a little bit more. And there's some retrospective studies on it. But certainly that would be a concern if we go beyond 14 days of therapy with linezolid. But I don't have too much experience in seeing that in my practice. Yeah. Do you have any that you wanted to share? No. Okay. Just thought I would check. Yeah. Yes.
For like the POA lacking rats from that China study, do you have any concerns there as far as like don't have seplex in MIC, may or may not have Moxlab MIC, you know, they're only PKPD optimized at 2, which probably majority biased to other.
Yeah.
I guess all you need like what's your favorite POA lactate?
Yeah. So this is a great question. And we also have a little bit of an interesting kind of scenario at our site. So we actually don't get MICs for all of our pathogens. And so we don't get those in those situations. What I think is interesting for the most low-risk patients that have a urinary source, an E. coli bacteremia, from that paper by Von Dock and colleagues, and in listening to some of the interviews of these different leaders of these trials, the question is really how important are those extra couple days of oral beta-lactam? Like, is it really making a difference? So that's one thing, you know, is that 3 to 5 days of IV therapy really enough? And then we're just kind of doing a little bit of extra cleanup. So that's one thing to consider. We traditionally, on our initial algorithm, did recommend cefpodoxime at 400 milligrams twice daily, and we've had good response with that. Now we've systematized, and we have other like ID pharmacists coming in from other hospitals who have had more experience using amoxicillin or amoxiclav. We've certainly used a good amount of amoxiclav as well. I think where the challenges come in with amoxicillin and cephalexin is that you have to dose them more frequently. And so then we get into potential adherence issues with the patients. And I wonder if that Kaiser Permanente study saw more readmissions because of potential adherence issues. So there's really a lot to weigh and balance when we talk about the beta-lactams. It's not just the bioavailability, the serum concentrations, it's also that adherence, how frequently do they have to take it. So we liked the cefpodoxime. I think cefadroxil would be such a great option. You know, 90% oral bioavailability, you take it twice a day, but we just don't really have the susceptibility results even for it, or really the breakpoints for it for bacteremia. So that's a bit of a challenge, and we haven't used that for those reasons. So I would say our mainstays are really cefpodoxime, amoxicillin, amoxiclav. The cephalexin, you know, if we've got a patient with end-stage renal disease where we need less frequent dosing, might be a great option in them. I'm hoping that those 3 randomized controlled trials with the PO therapy will shed a little bit more light on the beta-lactams, but we'll see what comes out of those. Yes?
Kind of thinking back, you know, on this question too, but the oral beta-lactam and gram-positive, like our ID really likes like cephalexin, and specifically like I must say uncomplicated bacteremia. So I'm wondering, I know there's very limited data, and I'm waiting for staff for more data, but do you guys ever use oral beta-lactams as a step down for MSSA or complicated bacteremia as a source control?
We have a little bit more hesitancy there, and more often than not, usually linezolid. We have used a little bit of you know, cephalexin, beta-lactams, but we've seen a lot more with linezolid in those situations. Yeah, but hopefully that SNAP trial, like you said, will shed a little bit more light there. That was the difficulty with this presentation, is there's so many things that are